Greetings. This was the State of the Science for Research presentation at the Western Institute of Nursing Research Conference 2023 in Tucson, Arizona. It is represented here with permission by the Western Institute of Nursing Research. I'm Dr. Rochelle or Shelly Fritz, Associate Professor at Washington State University. It is my pleasure to talk to you today about artificial intelligence and the journey towards health equity. What makes this topic particularly important is the structural way with which AI is developed using big data and implemented in systems like healthcare, and thus its potential for impact at scale. Informing my thinking around AI are these information sources and the interests and goals of the funding mechanisms who have supported my research. I don't have any financial disclosures to make regarding any of the content I'll discuss today. I should, however, disclose that I am an early adopter of technology by necessity. My spouse and my kids are all computer scientists and adopters of everything technology, early adopters, even in some case innovators, so I live with a lot of tech on the home front. And these experiences, along with working with an AI team at our university for a decade, inform my thinking about the topic and content that I'll discuss today. One thing that I want to make clear is that I am not an AI expert. I am simply a nurse who decided, somewhat reluctantly, that technology was important enough to my patient outcomes that I needed to get involved with it upstream. My goals today are to introduce you to how AI works, to empower you and hopefully inspire you to get involved in some way, to discuss the state of artificial intelligence in healthcare, and to examine healthcare AI through an ethical lens. I hope to present a balanced perspective on AI because I think that it's important to have balance as we move forward. There's a lot of hype around AI and there's a lot of fear, but I don't want us to get too hyped up because if we do, we'll likely create technologies that will do harm to at least some. And if we hide behind the fear, we will lose our opportunity as nurse scientists to embed nursing values in the AI that will most definitely be used on our patients. In the last 5 years, hundreds of scholarly articles have been published showing AI's promise for improving healthcare. 27 different studies have compared AI to physicians, and in tasks like diagnosing, have shown that the AI is more accurate and faster. 14 AIs have been granted FDA approval for things like atrial fibrillation detection, scoring coronary calcium, and diagnosing diseases of the brain, heart, lungs, and eyes. I think that the path forward is proceeding with a path that involves caution. This is a middle path that I like to seek. I've learned that in order to know whether you're on this path of caution, there's a few road signs that can guide us. But to recognize these road signs, we need a basic understanding of how AI works. So let's take a moment to cover a few of the basics, and then we'll examine AI through an ethical lens. AI is typically thought of as the performing of tasks that normally require human intelligence. There's two main categories of AI. AGI, which is artificial general intelligence, and this is the kind of AI that you see in the movies, and it does not exist yet. Artificial narrow intelligence is all of the AI that's used on the planet today. Narrow intelligence can often conduct specific tasks better than its human counterparts by looking for patterns in the data that often humans cannot see. A really great example of probably one of the most sophisticated narrow AIs is the Tesla car in self-driving mode. Even though it does really good traveling down the freeway at 75, 85, 95 miles per hour and dealing with the world in real time, it is really just a series of narrow tasks strung together to accomplish a goal. AI is a broad field with several subfields. I want you to think of this in terms of the blue buckets and the red buckets, with the main difference between the blue and red buckets being the amount of human supervision. In machine learning, which was where AI started, humans set the rules and parameters, and humans verify the data for ground truth, meaning the data that we feed to the machine for it to learn from represents something in the real world that we as humans recognize it actually represents. In the red buckets, no one is setting the rules or giving it parameters. Hence, these AIs are not limited by human knowledge or bound by human time and effort. So these AIs have the potential to produce unbounded knowledge derived from whatever data are available to it. So you can imagine that whatever the data are comprised of or not comprised of that's fed to the machine is hugely important to what the machine produces. Deep learning is where most of AI for healthcare is coming from. Deep learning became possible around 2012 when the fields of mathematics and computer science advanced significantly, and that converged with advances in hardware, where microprocessors became smaller and smaller and were able to process larger amounts of data much faster. So because deep learning is where most of healthcare AI is coming from, and because the details within deep learning are largely what's impacting health equity's AI target, be that a system, a population, or an individual person, let's take a little deeper look at it. For simplicity, I'll use a brain image that will pretend we're asking the neural network to analyze. But instead of an image, you could train a neural network to analyze other types of data, like an audio recording or big data from smartwatches, or anything that is already digitized, which is basically the entire electronic health record. In our example, think of this image as a grid of numbers where each number represents the brightness of a point on the image. These numbers are fed to a set of nodes or neurons as inputs. Inputs can be raw data, and they can be features, which are measurable properties in the data, kind of like explanatory variables used in linear regression models. Some inputs are proxies for things like socioeconomic status or social determinants of health. And some of the common proxies in healthcare are race, gender, age, education level, insurance payer, and zip code. Next, the data are fed into a network of neurons, which are mathematical functions. And the neurons take multiple inputs and consolidate them into a single numeric output. Each layer consists of many neurons whose outputs become all of the inputs to the next layer of neurons. You can imagine that the first layer, which involves recognizing the existence of simple features like lines, could be fed into the next layer, which can recognize shapes from those lines. This process continues, allowing the network to recognize more and more complicated visual patterns, like structures derived from those shapes, until the AI is able to generate an output or a specific finding like there's a tumor or no tumor. Depending on the data's complexity, there can be hundreds of layers to the network. The effect of the highly interconnected sets of layers is not well understood by humans and is considered the black box area of AI. The behaviors within this black box are directly affected by the training data fed to the network during the training process. But don't get too uptight about this, because remember, healthcare has been using aspirin for 165 years, and we still don't understand fully the mechanisms underlying its effects. Deep learning is already being used in these 5 areas of healthcare. Monitoring includes accomplishments both in acute care and at home. AIs in EHRs are showing up as alerts and decision support tools. And outside the hospital, it's showing up in wearables and home monitoring devices. Diagnostics is by far the fastest growing area of AI in healthcare, and it's where most of the publications are happening. And it's an area that is exhibiting inequities. Despite the impressive accomplishments, some image recognition AIs are struggling with features like pigmentation and facial structure and breast density, which can vary depending on ancestry. Treatment planning and risk stratification are inherently connected. Treatment planning is mostly directed at individual risks for poor outcomes, and risk stratification is targeting the costs of those outcomes. Currently, treatment planning and risk stratification are applied to patients at an individual level, where the AI has automatically already placed that individual within a group of like people. These likenesses could be by race, age, gender, or they could be things like similar diagnosis and lab results, so diabetes and A1C results, or it could be by similar zip code. Because race is a socially constructed idea, using it for treatment planning and risk stratification requires some very careful thinking, especially if the AI is learning from all the EHR data, including things like the faces of patients, which are in all EHRs now, and the frequency and type of care that patients engage with, and where geographically they engage with it. Health information is another area being impacted by AI. A key concept here is that data and information are inextricably tied in the world of AI. You can't have one without the other. And together, they wield a ton of influence because data is the new oil and information is power. Now, if data and information are power, Google has it. Google is one of several tech companies moving into the healthcare field, mostly on the back end, with AIs supporting medical image recognition and for research. But we'll see if this changes in the future and they move towards the front end like we've seen Amazon do. Google receives more than 1 billion health questions a day and responds to about 70,000 inquiries a minute. They now have a whole team dedicated to achieving health equity, and they are using their data dominance to grow their influence in the healthcare space. This is a screenshot of their website. Apple is doing something similar. They've primarily been on the back end with research, but some of you may have already brought it to the front end for yourselves by connecting your MyChart to your Apple Health app. And Microsoft is getting in the game too. On the research side of things, there's a couple of AIs that I want to talk about. The first is Semantic Scholar, which has become a major player for information generation in research. This is a tool that makes it easier and faster for researchers to find relevant papers and quickly understand specific sectors of literature. And because systematic reviews are a major way of generating information in healthcare today, and because there are so many publications produced every single day making systematic reviews harder, there's a couple of AIs that can help with this. One is Distiller SR, another is ASR, and there are several others out there. These are just a couple examples. But these are AIs that can assist with your searches for systematic reviews and help you sort, rank, and analyze the publications. These AIs can also act as a third or fourth artificial independent reviewer. And for healthcare information generation, let's not forget about OpenAI's ChatGPT. This AI is already changing everything about how I personally access, create, and use information. Instead of going to Google and getting the top 100 hits on any topic that I'm looking at, I now go to ChatGPT, and it not only goes out and gets those top 100 hits, but it gleans information from everything that's available on the internet, the entire internet, on that topic. And it produces a nice little summary, an interpretation that's written as a narrative mini essay, like a human would, already interpreting that information for me. I liken this to a radiologist's narrative interpretation of an X-ray. Now, given that ChatGPT is trained on the entirety of the internet up through 2021, the critical question is, will it be able to parse fact from fiction or conspiracy? No one knows yet how this AI is going to perform over time. And given the struggle with clear, factual messaging from scientists to the public of information during COVID, how this AI will learn from all of the internet data that's out there should be something of interest to everyone working in healthcare. It's a little bit of the Wild West out there right now, but we have to keep an eye on this. What we do know for sure is that OpenAI, who created ChatGPT, is formally saying that it is their goal to create the first artificial general intelligence. So no patient will escape contact with AI, nor will any nurse. And although some show promise, others are making incorrect underlying abstractions from the data in that black box area, leading to inappropriate recommendations, causing some 41% of C-suite executives to suspend AI tools due to ethical concerns. So where does bias creep in? Where does the rubber meet the road with regard to equity? In AI, bias is typically defined as the difference in performance between subgroups for a predictive task. When differences occur, unfair decisions can target certain subgroups. This is particularly important with predictive models supporting clinical decision-making because it can lead to unfair treatment where like is not treated as like. There's three main places in the AI design loop where bias can be introduced. The first is at the user interface. Many AI models rely on user-generated data from iterative interactions with the model, so any inherent biases that are brought into this interaction space by a human who is biased will enter into the data because this user interaction space is always monitored and generating new data for the model to learn on. So those human biases will be brought forward into the data sets that the AI is learning from. You can also have algorithms that are already biased that come into that user interaction space. And those already biased algorithms will inherently generate data from humans who are biased that then also enters the data space, the data that the AI is learning from. Now, the data itself can also contain biases like demographic representations that are just too homogeneous. And aggregation bias is something of concern as well. This is a common issue impacting precision medicine ideals. Aggregation bias is when false conclusions are drawn for the individual based on its likeness to a group. This is similar to being outside the bell curve, but being treated as if you're in the middle of it. Temporal data are especially problematic. Temporal data are used for a lot of the monitoring AI that are from that monitoring section that I talked about earlier. It's popular to use cross-sectional cohort data to achieve heterogeneity. However, disaggregation of this data with a longitudinal timeline may actually show an opposite effect. In addition, algorithms can have biases. Algorithmic bias is basically when there's a design flaw. In this case, the data aren't particularly biased, but the output is. If a predictive model is trained using existing data that overrepresents certain groups and underrepresents others, it may result in an algorithm making predictions or decisions that favor certain groups over others. For example, a predictive model for heart failure aimed at treatment planning that's trained on a primarily white demographic will not be able to account for the fact that Black women are 2.5 times more likely to die from heart failure and at a younger age than their white counterparts. Because this pattern was not trained on data that included this demographic, if it's primarily trained on the white demographic, it will not be able to accurately predict or suggest treatment planning for Black women. I'm convinced of all the bias problems that the biggest problem we have right now is the data sets themselves. Data fed to a lot of the models to date are just too homogeneous, and this is because of existing societal inequities by race, class, and geography, or where we live. This leaves deep learning models unable to learn appropriately. The key thing to remember here is the people who are represented in the data and the people who are not represented in the data. As nurses, we are a responsible party in the care that people receive, so it's partly on us to ensure that we don't end up with intelligent health technologies that are what author Kathy O'Neill calls weapons of math destruction, MATH. To give you an example of just how skewed a lot of healthcare data are that are being used to train algorithms today, let's take a look at a study published just 3 weeks ago by Yang and team out of the UK. They conducted a multi-year prospective study that used an algorithm trained on EHR data to predict COVID-19 in ED patients in 4 major hospitals in the UK. And you can see that the patients in this study were overwhelmingly white. Unfortunately, this is the case with most data sets I'm seeing in the literature about healthcare algorithms. Now, thank goodness that this team recognized the need to mitigate racial bias here. So they used a technique called adversarial training. And this is a technique where you train 2 algorithms in parallel at the same time. And in the first algorithm, you don't account for sensitive features like race, ethnicity, gender, or age. And in the second algorithm, you intentionally exploit sensitive features, and you train these over time in parallel, ultimately merging them together into an algorithm that behaves more fairly. Now, there's a few limitations with the work that this UK team did, but for the sake of time, I'll let you look at those if you so choose on your own. But they made two huge contributions to healthcare. The first was that they used a prospective study design. There's just a small handful of studies in the last 5 years that have used prospective design, like 6 to 8 only, out of those hundreds that I said have been published, of which most of them are using existing data and retrospective analysis. So being able to test this algorithm in real time was really an asset. The second thing was that this anti-bias algorithm appears to be generalizable beyond the specific use case of predicting COVID-19 in the ED. So what is the role of the nurse scientist in all of this? My premise is that we can be involved at all levels, from the very beginning envisioning a technology to the very end where we implement and test, and anywhere in between all the way down into the details of coding. Nurses are well positioned to help answer some of the most pressing questions that are being asked by society about AI. Just a couple of years ago, a team at Stanford was tasked with coming up with what are the top questions that society should be asking about the future of AI, and what are some of the answers. This team came up with 12 top questions, of which one of them was, what are the most pressing challenges and significant opportunities in the use of artificial intelligence to provide physical and emotional care to people in need? And their follow-on question was, is coding caring possible? Now, I cannot think of a better discussion table for a nurse scientist to be at than that one. I think the biggest nursing science problem in relation to AI right now is that we're just absent from so much of it. When I go to the websites of almost any company marketing AI-driven healthcare solutions like Apple, Google, Amazon, or startups like LookDeep and StatCare who are focused on nursing support specifically, or I look at AI research teams across the nation, I might see a chief medical officer listed or someone from a department of medicine, but I rarely, if ever, see a nurse or a college of nursing listed. Why is that? Now, as nurse scientists, just because we would be at the table, we aren't the be-all, end-all. It doesn't mean that suddenly AI for healthcare is going to work and be more equitable. But I'll be honest with you. I worry that if we don't have a plan for getting involved as individual nurse scientists, or if we don't have a message as a discipline for what tables we expect to be at and what we expect of AI in the future of healthcare, I think that achieving health equity in an era of AI will be that much harder. With that plea, I'll share a few examples from my own work where nursing science and the study of the human response to illness became the driver of an NINR study. So this work falls within the monitoring category that I showed earlier. Our multidisciplinary team is designing a smart home capable of automatically monitoring and recognizing changes in health states of older adults who are managing chronic conditions at home. So we're basically putting sensors, like you see here on the left of the screen, in people's homes, and we're monitoring their movement patterns around the home. We don't use any cameras or microphones, just motion sensors. This is the basic premise that when you don't feel well, you move differently. And we believe that we can automate recognition of that. A quick example is like a heart failure patient who normally sleeps in their bed every night, but for the last 2 nights slept in their recliner chair. That's a clinically relevant change that nurses could get involved with that might result in mitigating an emergency visit. On the right, you see a data dashboard that we created that's interactive, where nurses can zoom in on specific motion patterns or behaviors that have changed that we think are clinically relevant, like a change in your sleeping location, or how many times you've gone to the bathroom in the last 24 hours. The color scheme on the right, using green and yellow, and there could be blue and red, is mocked up from the emergency department triage coloring scheme. So you can see that on this day, this person was functioning normally. In that same NINR funded study, I'll show you one example of how we captured adherence to a heart failure treatment plan that included PRN use of diuretics. You can see on the x-axis we have the ticks are at 24-hour segments, and the y-axis is the number of sensor readings. The green lines represent various features that we look at related to bathroom use, like the frequency of bathroom use or the duration of time in the bathroom. And here you can see that the green lines are increasing and then decreasing, and this is aligned with the participants' use of a diuretic as they had an exacerbation. You can see they went to the bathroom less, they went to the bathroom more as they used a diuretic, and then when they stopped, it dropped off again. Just an example of digitized data where we can automate an algorithm around recognizing these changes. So with that work in mind, which was primarily conducted on a homogeneous demographic, primarily white folks who were upper or middle class, the nursing team did what nurses do. We asked a couple of really key questions in our pursuit of equity by design. We asked, what does our nearly all-white sample mean for persons not in the dominant group? And how does training our algorithm primarily on persons of higher income mean for older adults experiencing poverty? After all, about 90% of older adults are living on fixed incomes. And thanks to funding from the Betty Irene Moore Fellowship for Nurse Leaders and Innovators, our nursing team is now leading a new study with the goal of building a low-cost smart home capable of real-time alerting, where we embed the technology in a response system that includes trusted community health workers having RN oversight. Our main community partners in this study are the local housing authority and 2 clinics who primarily serve immigrants. All of our participants are living in poverty, and over half are persons of color or immigrants. This is a picture of the dashboard that we're creating for that particular study. We've learned a ton about real-world inequities, and it's not just on the algorithm side of things. It's on where we deploy these sophisticated technologies. In our low-income housing units, we find that there are just not enough outlets. Many of the rooms only have 1 outlet, and we're lucky if there's 2. And what we found is that there's power strips already plugged in, both in the top and the bottom, and all those power strip outlets are taken. And so we end up having to negotiate for just 1 outlet to plug in our health monitoring system. And the conversation sometimes goes like this: would you be willing to live with just 1 lamp in the bedroom instead of 2 so that you could have a health monitoring system? Or would you be willing to use only the clock in the kitchen and not the one in the living room so that you could have a health monitoring system? And maybe having 2 lamps in the bedroom is more important than a health monitoring system. I don't know. But what I can tell you is these are not negotiations or conversations that we had with the participants in our study who were of higher income. So we've learned a ton about equity, and this leads us to think about, how do we assign value to an AI? I think nurse scientists are well positioned to examine an AI's value. And I think there's 4 lenses that we really need to look at to think about value. The first is the patient perspective. At an individual level, we have found that we have to understand a few things about why someone would adopt or accept our technology and how it will be used if they do agree to it being in their home. We learned through some of our qualitative research that older adults in our first NINR funded study really need to be able to trust the technology, and that a lot of times that trust is actually directed at the human introducing the technology. So that's a really important concept. We also learned, they told us that they don't mind being watched over. They kind of like that, but they don't want to be watched. And they don't want their own privacy invaded any more than it has to be. We also learned that it's important to determine the likelihood of use when no one else is around or looking. We asked those same set of questions then to a group of older Asian immigrants. And guess what? They told us basically all the same things. But they had one additional key message for us that was really important to them. And that was that they did not want the smart home to dismantle or damage cultural expectations of the children and grandchildren caring for their elders as they age. And that's an example of why it is important to look from a population perspective as well. We also need to look at the nurse perspective. If we're not obtaining the perspective of frontline nurses, we are just not getting pragmatic information that will help us with design and deploying these technologies in a meaningful way. I think that we can also use the NINR framework for research to really think about and guide us in our envisioning and our deploying of AIs in healthcare. They could be designed for any of the settings that are shown here on NINR's framework, but they also should be designed to address one of the main areas that they've called out here in the center of the circle. Nurse scientists can also ask questions about equity and economic value. I know as nurses we don't like to talk about money, but money is really an equity issue. And I think a key question here that we have to ask is the technology likely to be self-sustaining, meaning it saves cost either on the front end or the back end so that it's positioned to lower healthcare GDP in the US. And thus, it will be around for the long haul. If this economic question cannot be answered satisfactorily, the technology is likely going to be a fad, and we should not be wasting our time on it, and we should for sure not be wasting our patients' time and effort on it. And last but not least, it's important to understand AI's added value through an ethical lens. Now, you are all probably very familiar with these principles, but there's a few ideas that I want to highlight here specifically regarding AI. The first is in non-maleficence. Legislation and laws are light years behind where we are with technology and AI. So it's on us as researchers to make sure that we're using techniques and tools that safeguard patient data. And one of these is federated learning. A lot of AIs are being developed and being trained on EHR data. And federated learning is a tool that can be used where you send the model to train at the local hospital or clinic level, and then the only thing that leaves that hospital system are the outputs that the model produces based on the data that it's trained on. But the data always stay local, meaning that there's less access for nefarious actors to get a hold of it or for data breaches to happen. Another thing regarding non-maleficence that I think is important to think about is we should really be demanding a decentralized, authoritative approach to shutting down an AI in healthcare. I liken this to what the airline industry does with pilots and autopilot in every airplane in the sky. Autonomy is another really interesting area that we have to think about, and I think it's ripe for nursing research. The autonomy includes the ideas of right to self-determination and informed consent and agency. And there's two main ideas I want to bring forward here. The first is, how do we obtain informed consent from someone who doesn't really understand how an AI works? We deal with this enrolling older adults in our smart home studies and just simply trying to get informed consent and making sure that we're careful about that on the research front. But in the real world of healthcare, how do we ensure that someone is actually providing informed consent? And taking this a step further, how do you even accomplish this at all when there's such a thing as a black box? I don't have the answers, but I think that as nurses, we should be thinking about these things. The other area regards agency, and this really involves the question of how does one keep agency while seeking healthcare in an AI-driven healthcare system that having such opaque yet structural impact on things like health monitoring, diagnosing, and treatment planning. To address some of these questions, AI leaders have embraced a new ethical principle that they call explainability. Now, this is the idea that an AI's output includes an explanation of how it came to its conclusions and how accurate it deems its conclusions are, and that it does this using descriptions that humans can understand. Currently, there's no regulation or really even transparency around how accurate an AI is performing and what it decided to measure. And although there is a balance between intellectual property, which is a big idea in all of this technology development, and although there's this balance between intellectual property and transparency, as end users and as nurse scientists, I think we should demand at a minimum to understand how AI impacts equity and that this aspect should never be covered by intellectual property. Now, there's a few organizations that I've listed here on the left that have published value assessment frameworks for AI. And some of them have some tools, none of them are validated, but I don't have time to go through all of them. So what I did was I put their main principles or tenets or constructs into a word cloud, and you can see here there's very little overlap. Look at all of those constructs or ideas that do not overlap at all. And what this tells me is that this area of frameworks and developing validated tools to measure and value AI in healthcare is a wide open area. And so if you're a nurse who likes to develop and validate tools, this is an area where it would be great for you to get involved. In all honesty, I just really love this harms assessment tool that was developed by Microsoft's unfortunately now disbanded ethics team. It's just really straightforward and it gets to the point. This assessment is designed to guide you in envisioning harm along 4 vectors: risk of injury, denial of consequential service, infringement on human rights, and erosion of social and democratic structures. And although this wasn't created for healthcare AI in particular, I really think it can apply. With this tool, it helps you draw conclusions for the potential of risk being low, moderate, or high. So how do we solve the equity problem that's emerging in healthcare AI? I think it's going to take a multifaceted approach, but the bottom line is that I go back to that the data and the data sets are the problem. And so if we are going to diversify our data sets, we have to be able to build trust with communities of color, communities of any population that we need to increase representation of in the data. And in order to do that, we have to diversify our research teams, which means that every single one of us as a start can take a look at our own research teams and do some introspection and ask ourselves, what do our research teams look like? And what I will tell you is that if your research team looks like you, acts like you, believes like you, lives like you, it is not very diverse. And you're going to be unable to build the trust that you need with the communities that need more representation in the data. And so I encourage you to think about what's just one step that you can take to diversify your team. Because again, if all the people around you are like you, it is frankly just no longer acceptable, and it's dangerous for the future. So we need nurse scientists to move forward with AI in healthcare and to be people who can have some foresight, who can think about what does the future look like, who are willing to get into those journals where the brand new ideas are being put forth, not the scholarly journals, but things like Wired and The Verge, who can read about the technologies of the future and be able to imagine how that's going to work in healthcare. And as part of that imagination, have a moral imagination. We need nurse scientists who have endurance and are adaptable, because this is a fast moving space. And we need nurse scientists who have good communication skills outside of their own disciplines, with computer science, with engineering, with math. And I would say that at least some of us, in order to improve our communication at a detailed level, should learn how to code. I mentioned at our research conference that my research assistant, Katie Wisney, who's about to graduate with her PhD, is the first nurse on our team who learned how to code. And I think she would attest to the fact that her influence with the engineering and computer science team in some of the details of how they are coding the algorithms that we're using for our smart homes has been just enormous since she learned how to code. And she doesn't do it at a very sophisticated level. I mean, she does pretty darn great. But what I'm saying is that we just need a basic understanding, and I think that it will give us really an outsized influence. In addition, we need nurse scientists who have guts and grit, because it's going to take that to hang on to this field as it rapidly moves. But in the end, ultimately, nurse scientists who never forget that we are here for our patients. So my objectives today were to introduce you to how AI works, to hopefully empower you and inspire you in some way to get involved, to discuss the state of artificial intelligence in healthcare and examine it through an equity lens. We've covered a lot of territory in meeting these objectives, but hopefully I've given you a sense of the potential positive power of AI and a sense that achieving health equity in an era of AI will require astuteness, but that nurse scientists are well positioned to be part of the AI DevOps teams of the future. Thank you for taking the time to listen to this presentation. I provided in the talk my top 10 references, but I am definitely willing to attach, and we'll look how to do this, all of my references that were used in the development of this presentation. And I am grateful again for your time, and please reach out to me if you have any questions.